I've been asked to elaborate a bit on the management of acute hepatitis B when it becomes acute liver failure, and to expand on the different types that we see. So again, only 1% of acute hepatitis B evolves to acute liver failure, and again, the pathogenesis is poorly understood but thought to be an overactive immune system. We distinguish the acute hepatitis cases, the primary infections, from reactivation in a couple of ways. First of all, clinically, the acute infection patient tends to be a young patient with a new exposure, often a new sex partner, or in the US, often exposure to injection drugs. However, the reactivation patient would be an older patient, and they can have spontaneous reactivation, just a flare of disease that we don't understand the cause of, in the absence of any immunosuppression. Those patients tend to do quite poorly, but you would imagine that that patient would be an Asian American, older patient, and the flare in disease occurs without obvious cause. But the third form of this is the reactivation when one is exposed for the first time to, let's say, chemotherapy for lymphoma, the 4-drug regimen that's sometimes referred to as CHOP, or CHOP-R, which is actually 5 drugs, including rituximab. In those patients, the disease comes on very rapidly, and they do quite poorly. Even with transplantation, they may do poorly post-transplant. Often they're not considered for transplant if they have underlying malignancy that's undergoing treatment but has not been cured. We can distinguish them serologically. Both will be HBsAg positive. Both may have high viral loads, but the acute infection will have typically IgM anti-HBC positivity in high titer, whereas the reactivation sometimes will be anti-core positive, but sometimes will not be anti-core IgM positive. Of course, every patient will be anti-core total antibody positive, but only the acutes and some of the reactivations will be anti-HBC IgM positive. I hope I made that clear. Now, what the pathogenesis of the reactivations is remains a mystery, although what we see, and I showed in the prior slides, is that in reactivation, the liver is filled with viral particles, and the nuclei of the hepatocytes are filled with the core antigen. It seems like in that setting, the virus itself may be toxic to the liver cells, whereas in acute infection, we saw very little virus present, suggesting that the immune system was dealing with the infection, had eradicated most of the infected cells by killing them off. So the pathogenesis of reactivation seems to be totally different from that of de novo or primary acute infection. As far as treatment goes, we would generally use a nucleoside analog in any patient that seemed to have more than just mild or moderate acute hepatitis B. For example, if someone has an aminotransferase over 2,000 or bilirubin over 15 micrograms per deciliter, someone who looks quite ill or who has had more than a week of ongoing jaundice without any signs of improvement, these would be some of the things that we would think would prompt using a nucleoside analog for this patient. The nucleoside analog of choice would be either tenofovir or entecavir, at least in this country. Lamivudine can be used for short periods of time, but as you know, is associated with drug-resistant mutations. The problem with the nucleoside analogs is they don't rapidly improve either the aminotransferases or the viral loads, so it often takes several weeks before improvement is seen. There does not seem to be any downside or harm to giving nucleoside analogs in this setting in terms of whether the patients will eventually resolve their acute infection. As far as transplantation goes, patients with acute, severe, fulminant hepatitis B can be considered for transplant and are quite good transplant candidates. However, they will have to receive hyperimmune globulin and a nucleoside analog, typically for some time post-transplant, so that the new organ does not get infected, or if it does, the infection is suppressed. Thank you.